Okay, it is recording. So I think I will just start and go ahead, and then whoever joins can just join as we go along. Is that okay?
Perfect, thank you.
Okay, so hello everyone that's here currently. I am going to be talking about acute kidney injury. I thought this is quite a nice and important topic to speak about because unfortunately we aren't physicians and we aren't working in ICU, but it's also very important for us as ED doctors to recognize and manage acute kidney injury in the ED already to prevent the high mortality and complications that is associated with it. This is just an overview of my presentation today. I've just added some content so that you can see what I will be speaking about in the topics today. So I will start with the overview now. So basically what AKI is, I'm just going to refer to it as AKI because it's a very long term. It's defined as an abrupt or basically an acute onset within 7 days and a sustained of more than 24 hours decline in your renal function. And it's basically a syndrome of some or other underlying disease process. So you can get a spectrum which is ranging from mild to severe in the renal dysfunction. The reason why it's so important is because it's associated with a high mortality in critically ill patients that have AKI, up to 50 to 60%. And when you recognize it early enough and treat it correctly, you can actually get a recovery of your renal function as high as 90%. But even despite that, sometimes 50% of surviving patients might not even return to their baseline function. So that is the issue with AKI. So when it comes to defining AKI objectively, there are a few criteria that we can use. I'm going to speak about two. The one is the KDIGO, which stands for Kidney Disease Improving Global Outcomes, which basically defines acute kidney injury into 3 stages based on the creatinine and the urine output criteria. So as you can see there, I've added the image. Based on the creatinine on stage 1, it's about 1.5 to 1.9 times the baseline or more than 0.3 milligrams per deciliter, or the urine output less than 0.5 moles per kg per hour for 6 to 12 hours. So I won't read out all of those, but as you can see, it's quite a nice little objective way to define AKI based on 3 stages of severity. Okay. And then the rifle criteria is also another way to objectively define or stage your AKI. So rifle stands for risk, injury, failure, loss, and E for ESRD. So it's also based on your creatinine criteria as well as urine output criteria. And in the very mild stages, you basically have a risk for AKI, and that's basically based on your creatinine and your urine output shown there. And then as you go further down, you get your injury, your failure, your loss, and your ESRD, which is your end-stage renal disease, which is basically present for more than 3 months. So that's another way that you can basically classify AKI based on that. So looking at your risk factors for AKI, you can basically categorize them into 2 categories. You get your pre-existing risk factors, which is typically your age more than 62 years, so your elderly patients, those that already have an underlying chronic kidney disease, and obviously your comorbidities like hypertension, diabetes, and other cardiovascular comorbidities put them at greater risk of developing AKI. Then you get your exposures. So this is what patients are exposed to, which includes sepsis, trauma, burns, certain nephrotoxins, which I will mention later on in the talk. Obviously, surgical patients, particularly in the post-operative period, are susceptible for developing AKI. And those in ICU or those on mechanical ventilation are also at risk for developing an AKI. So when it comes to AKI, there are 3 major categories into which we place them, and we kind of have to sort of determine which category it is so that we can then start managing it appropriately. So you get your pre-renal AKI, your intrinsic renal AKI, and then your post-renal or obstructive AKI. So pre-renal is caused by a decreased perfusion to your kidney. So anything that causes shock will give you a pre-renal AKI. So typically that's hypovolemia. So you get your renal and extra-renal causes. So renal would be things like anything that causes diuresis by the kidneys, and extra-renal would be like your GI losses, hemorrhage, and things like third spacing, even sepsis, causing a relative hypovolemia. And then your other causes of shock, so your cardiogenic, your distributive, which will include like your anaphylactic shock, your neurogenic, as well as your septic shock, and obstructive shock as well. Then you get your cardiorenal and hepatorenal syndromes, which is basically where your diseases of your heart and your liver actually also cause dysfunction in your renal or kidney dysfunction as well. So it is quite a complicated syndrome, but that typically causes a pre-renal sort of AKI picture. And then hypertensive emergency as well can cause a pre-renal picture. So your intrinsic renal AKI is anything that causes direct injury to your renal parenchyma. So you can basically classify them into vascular diseases, of which you get your large, medium, and small vessel diseases. So large would be things like your renal artery thrombosis or stenosis and renal vein thrombosis, as well as your arthroembolic diseases. And then your medium and small vessel would be things like your scleroderma, as well as your hemolytic uremic syndrome, as well as TTP. Then your glomerular or systemic diseases, SLE, infective endocarditis, and your HIV-associated nephropathies, and the systemic vasculitis. And then primary renal diseases, typically your post-strep and your other post-infectious glomerular nephritis, tubulointerstitial diseases caused by drugs, toxins, or sepsis, and your ATN, or acute tubular necrosis, basically can be caused by ischemia, myoglobinuria, and hemoglobinuria. And then other things, severe liver disease, like we spoke about as well, can cause a hepatorenal syndrome, as well as allergic reactions. Then your post-renal AKI is also very important to consider. So anything that causes an obstruction, which you can actually categorize it at the level of where the obstruction is. So you get obstruction in your intrarenal and ureteral places. So you get your stones, malignancies, you even get precipitations of certain substances and drugs, such as uric acid and oxalic acid, which you find in ethylene glycol poisoning, and your drugs being sulfonamide, methotrexate, and acyclovir. Then in your bladder, you get a stone, clot, prostate hypertrophy, bladder CA or neurogenic bladder can cause an obstruction at the bladder level. Your urethra, so you can get a stricture and phimosis that can occur there, as well as other causes, abdominal compartment syndrome, particularly if your pressure is more than 25, can actually cause an obstructive AKI. Then other drugs causing urinary retention, don't forget about your anticholinergics and pseudoephedrine, which can actually cause urinary retention and lead to an obstructive picture. So when it comes to AKI, you can actually define it as oliguric or non-oliguric. This is actually a nice little diagram, which is from the Internet Book of Critical Care. The nice thing about this is it actually gives you sort of an idea of where your cause is of your oliguric and your non-oliguric AKI. If it's non-oliguric, then it basically rules out a pre-renal cause. But if it's oliguric, it can be any of the three that can actually cause an AKI. So when it comes to, this is also a nice diagram, when it comes to an approach to oliguria, one of the first things you can easily rule out is if there's an obstruction. So because we have a nice ultrasound in the ED, we can use that to sort of look at the bladder and the kidneys to look for any hydronephrosis. And obviously, if a patient comes in with a blocked catheter that they've had for a while, that can also be one of the causes, and it's easy to just check and exclude that. If they don't have any obstruction, then you can start looking at their hemodynamics, and you can look for certain causes of shock. And based on that, you can see, are they hypervolemic? You can try and give them a fluid challenge. If they have a MAP that is inadequate, so they're hypertensive, you can try and give them a vasopressor, like your norepinephrine or your vasopressin. Or if they have myocardial dysfunction, basically causing cardiogenic shock, you can try them with an inotrope. Or if you suspect that the disease is intrarenal, you can do the furosemide stress test, which I'll talk about now as well. So then basically, based on that, it sort of guides you, not just blandly throwing fluids at every AKI, because not all AKI is treated with fluids. So the furosemide stress test is also actually a nice test to guide your resuscitation. So what it entails is basically a functioning kidney. In order for Lasix or furosemide to work, you need to have a functioning intact nephron. So the appropriate patients that can be considered for a furosemide stress test is if you felt that they're adequately resuscitated with your initial measures with fluids, but they still have a persistent oliguria. And if you feel that maybe a fluid or a vasopressor inotrope challenge wouldn't help, you can try the furosemide stress test. So you basically give them 1 milligram per kilogram IV bolus. That's if they are not on Lasix already. And if they're not, or if they are on Lasix, you basically give them a bit of a higher dose of 1.5 milligram per kg IV bolus. Then you monitor their urine output for the next 2 hours. And if they pass more than 200 mils, they actually pass the furosemide stress test. And what that means, that the cause is actually pre-renal. And you can try more with your fluid resuscitation or hemodynamic manipulation with your inotropes or vasopressors to try and see if the urine output improves. It also means that the urine output is a useful measurement of organ perfusion, and you can use that as a marker of when you are treating shocked patients. Now, if they don't produce 200 mils in 2 hours, it means they failed it. So what it means that there's actually an intrinsic cause of the renal failure, and this kidney is not able to produce urine, doesn't matter how much fluid or vasopressors or inotropes you give. So it actually means that giving any more of those could be detrimental to the kidneys, and it's usually an indication that you have to probably dialyze this kidney, because otherwise it's not going to produce any more urine. And it also means you can't use urine output as a marker for organ perfusion when you are monitoring shocked patients. When it comes to your lab test differences, and I know we all studied this in med school, I don't know how useful this would be in the ED, because, you know, we don't always do these tests in the ED, but just so that you know that there are certain indices on your markers that you can look for, whether it's pre-renal or renal causes. And one of them is your urea to creatinine ratio. And usually in pre-renal, it's over 20. So it means that your urea is actually much more markedly raised in comparison to your creatinine, whereas in an intrinsic renal cause, it would be less than 20. And then there's other markers as well, like your fraction of filtered sodium, the percentage, and all of that. But to be honest, I've never calculated that, so I don't know how useful that would be in an ED setting. You know, they say that one of the things that it has replaced is the furosemide stress test is actually also quite useful in determining whether it's pre-renal or renal. Then when it comes to doing a urine dipstick, because you always have to do a urine dipstick in any patient with a suspect of AKI, you've got certain diagnoses that causes kidney dysfunction, like your glomerulonephritis, acute interstitial nephritis, pyelonephritis, ATN, and rhabdomyolysis or hemolysis. So basically, this is also a nice little table from the Internet Book of Critical Care. And as you can see, there's certain things that you look out for on your dipstick for these diseases and certain things on microscopy. And there's obviously certain diagnostic clues on history and examination where you can sort of piece it all together to see what diagnosis you're dealing with. Yeah. Then I just added a slide or two about nephrotic versus nephritic syndrome, because that's always quite important for us to distinguish in the ED as well. So nephrotic syndrome is a disorder of the glomerulus. It's classically defined as proteinuria more than 3.5 grams a day. So these patients lose a lot of protein in their urine, and they usually get a hypoalbuminemia of less than 30 grams per liter. And basically the loss of protein leads to a decrease in oncotic pressure. So often these patients can be quite hypovolemic and hypotensive when they present. They also have hyperlipidemia and hypercoagulability as a result of the protein losing nephropathy. So the clinical presentation is they get very edematous, and in children it's classically periorbital edema with facial edema. In adults it's more your peripheral peripheral edema. They often complain of malaise, growth failure, and weight gain as a result of the hyperlipidemia. So treatments, there's a lot of subgroups of nephrotic syndrome, and the treatment is often directed at the underlying cause, but often the treatment principles there are your diuretics, antibiotics if you suspect an underlying infection, steroids, and albumin infusion in severe cases where they have severe albumin deficiency. Then nephritic syndrome is, in a way, it's different to nephrotic syndrome, primarily being the hematuria that they get and the red cell casts that you find on urine microscopy as a result of the inflammation of the glomeruli. They often also get the oliguria as well as hypertension. They often don't get as much proteinuria as in nephrotic syndrome. It's usually less than 3.5 grams per day. And then the complications is some patients actually present with quite devastating pulmonary hemorrhage. So it's also just important to take note of that. The treatment entails also diuretics, nitrates for pulmonary edema and your hypertension. If you suspect they are hypovolemic, some IV fluids, and you can consider steroids depending on the underlying subtype that you get with nephritic syndrome. So when it comes to AKI, there are some clinical manifestations. You get obviously your acute and your long-term manifestations. In the ED, this is actually quite a nice diagram that basically specifies the major underlying complications and clinical manifestations you get as a result. So with AKI, there are four main things that you have to look out for, and that's uremia, which basically causes bleeding, diathesis, and impaired mental state. So they get uremic encephalopathy, they get GI bleeds, as well as pericarditis. And your electrolyte disturbances, particularly being your hyperkalemia, which is deadly. It causes severe cardiac arrhythmias, muscle weakness, and paralysis. And your acid-base disturbance, which basically causes protein catabolism, reduced hepatic blood flow, and obviously hemodynamic instability. Fluid overload is also, they get the interstitial edema, so they get peripheral and pulmonary edema, and they also get increased intra-abdominal pressure from ascites as well. So when it comes to principles of management, it's useful to use a sort of ED approach to this because we often deal with these patients first line. So as always, ABCs are always important. First, your primary survey. And the main thing in AKI is there are two immediate life threats, which you always have to look out for and exclude, which is hyperkalemia and severe metabolic acidosis. So your ECG and your blood gas is obviously two adjuncts when it comes to investigating and looking out for these in order for you to pick them up early and treat them appropriately. So you always assess for your signs of shock based on your history or exam findings, and a point of care ultrasound, and you have to treat the shock based on type because this is often what causes your AKI as well. Then you assess for edema, your pulmonary and peripheral. If there are no signs of edema and basically fluid overload, you can trial these patients with a fluid challenge, but you have to be very, very careful not to give too much because they can easily become fluid overloaded, and that can further exacerbate the AKI. So the type of fluid that is actually preferred for hypovolemia and a normal serum bicarb is a balanced isotonic crystalloid, your Ringer's lactate or your plasma-like, because it actually has quite a neutral effect on the acid-base status and won't exacerbate the acidosis further. And when these patients present with hypovolemia and uremic acidosis, I know they often talk about the bicarb cocktail. So the isotonic bicarbonate is the fluid of choice, which is dextrose 5% water with 150 milliequivalent per liter of sodium bicarb. And then I know it's quite controversial when it comes to giving sodium bicarb for acidosis and renal failure, but I read up on the Bicar ICU trial, which basically summarizes that it decreases the need for dialysis or avoids dialysis. I know that it doesn't actually cause a decrease in the mortality in the long term. And usually they say a target pH of more than 7.2 is reasonable when you target a pH when you give bicarb for the acidosis. targeting euvolemia, so whether this is with the fluid resuscitation or diuresis. So it's very, very important to chart and input and output on these patients. You have to be strict with your fluids, and you have to make sure they all have catheters so that you can measure the output strictly as well, so that you don't under-resuscitate them or over-resuscitate them. And then when it comes to the blood pressure, you have to have adequate hemodynamic monitoring. So you have to have a map of more than 65 usually, which is generally adequate to perfuse your kidneys. But also remember that chronic hypertensive patients may require a map more than 80 because they usually have a higher set point when it comes to perfusing their kidneys. And then you look for any cause that you can identify and treat. One of which, don't forget to rule out and decompress an obstruction. That's why I'll talk about POCUS in the role of AKI later, but it's very useful to try and see if there's anything that you can decompress and start managing in terms of an obstructive point of view. Obviously, look for any sources of sepsis, things like that can be treated early on. And then stop any offending nephrotoxins, so any sort of drugs that patients may have been on that might be exacerbating their renal dysfunction, and adjust any renal metabolized drugs or antibiotics that you give, because this can also impact or further worsen their renal function. So this is quite a nice table. There's quite a few nephrotoxins actually. You can sort of divide them into pre-renal, intrinsic, and post-renal causes. Common ones are your diuretics, your ACE inhibitors, ARBs, NSAIDs, and then intrinsic, there's a lot more. I know that radio contrast dye nowadays they say that it doesn't really cause as much nephrotoxicity as it was believed to do so. But yeah, so there's actually quite a few that causes intrinsic renal damage. And post-renal, like I said, anything that causes sort of precipitants or precipitates that cause obstruction, like your sulfonides, cyclovir. And then indications for emergent dialysis. I like the mnemonic AEIOU because it's quite easy to remember. So acidemia, usually a pH of less than 7.1, despite your initial medical interventions with bicarb. Electrolyte disturbances, so this would be your refractory hypokalemia despite initial medical measures to try and shift it. Ingestion of nephrotoxins, which is removed by dialysis. I've also got a nice little mnemonic that I found for that I'll share now. And volume or persistent volume overload despite initial measures to try and diurese them, and especially those that cause severe pulmonary edema and respiratory failure. And then uremia, which actually causes hemorrhage, pericarditis, and encephalopathy. So there's a nice little mnemonic that is called I stumbled, which are toxins that are removed or amenable by hemodialysis. So that's your INH and isopropyl alcohol, salicylates, theophylline, uremia, methanol, barbiturates, lithium, ethylene glycol, and dabigatran. So as I mentioned, POCUS is always a very valuable tool in the ED, and it's no different in AKI. So it's very useful in determining the volume status of a patient. When you suspect that the patient is clinically fluid overloaded, you can look at your IVC as well as any features of pulmonary edema. And then obviously in obstructive causes, you look for hydronephrosis, and you can even measure a post-voidal residual volume. Usually a post-voidal residual volume of more than 100 mils is found in your BPH patients. And then another interesting one is the absence of your ureteral jets that you find in your bladder. It actually has a 90% positive predictive value for an acute obstruction. Then I found this nice grading system for your hydronephrosis when you look at it on point of care ultrasound. So grade 1 to grade 4. Grade 1, initially there's a dilation of your renal pelvis. Grade 2 is where your major calyces are dilated. Grade 3 is where also your minor calyces are dilated. And grade 4 is where everything is just super dilated with some cortical thinning as well. So that's severe hydronephrosis. Yeah, and that's it, my talk on AKI.
Thank you, Andy. I really like the fact that you took us through that. It's an important topic for the emergency department, and something that a lot of people forget, how important resuscitating the kidney is, right?
Yeah, definitely.
Can I ask for you to go to that really nice one of acute kidney injury in the ED? You had a really nice slide. Had like the thing in the middle. Yeah, there we go. Previous slide.
This one.
Yeah, that one. Yeah. That one was really nice.
Yes.
And I think it's important for us to kind of understand, are we looking for patients who are in multi-organ failure, and acute kidney injury is one of them. Often we have acid-base disturbances, and kind of how that is going to affect the patient in front of us. Our significant electrolyte disturbances, we always see these things. Patients have very strange acidotic looking blood gases. It's quite rare for us to see significant uremia in the ED, but when you do, and that means, the levels are really, really high already. And we do frequently see patients who have varying forms of fluid overload in the emergency department, some of which can be iatrogenic. Please remember in our department how easy it is to push a patient into pulmonary edema and fluid overload, especially when they're tiny, because we're not being particular about being pedantic about how much fluid, what's the weight of the child, and calculating the fluids and calculating the volume of fluids for our medications. So I think it's really important to kind of keep this, it's a really nice image sort of in our heads. This is a really good one.
Yeah.
I have a question for you, and it's probably a practical kind of question. So after having read the BiCAR ICU, is that going to change your clinical practice in any way?
No, because I don't think it really makes a difference in the ED. I don't know if it's really going to make a difference in the long term. I don't know.
So I kind of agree with you there. So it doesn't really change the mortality. So what is going to change our mortality? It's identifying it early, trying to prevent further worsening of the kidney, adequately resuscitating the patient. And if the patient is a candidate for dialysis, sort of going down that pathway, I'm sure you'll often find that somebody who's on their renal rotation in internal medicine will come along and change the fluids to all their weird, acute kidney injury cocktails and all of that, which is kind of weird. For us in the ED, I don't think there's any reason for us to faff with strange cocktails in the ED.
I don't think I've ever prescribed a renal cocktail in the ED.
And I really don't think that you should. So, the physicians will come along and prescribe all sorts of weird and wonderful things, and they can do that in the ward. But in the ED, please don't worry about those things, because there are, if you're running a soda-bic infusion, your sodium is going to start climbing, and then we're going to be dealing with hypernatremia and get very confused in the ED. So I'd recommend just sticking with a really nice balanced crystalloid like Belzar or like Ringer's lactate, and taking it from there. Obviously, if potassium is the issue, then we're going to have to look at shifting the potassium in the ED. So that might be an issue. And obviously trying to attend to electrolyte issues that might be causing hemodynamic instability in the emergency department.
Yeah.
Can I ask, can you go back to your pre-renal, intrarenal, and obstructive? So I kind of think that's how a lot of people sort of studied about it when they were at medical school. This is how we thought about it. And it's a nice way of trying to think about classifications. But remember that sometimes there can be a multifactorial.
They can sort of overlap.
Especially in our patients. So let's say if somebody's presenting with septic shock, how might there be a combination of these factors?
So with septic shock, they can actually have, they can definitely have a pre-renal component, but they can also have obviously an intrinsic renal component as well, because sepsis obviously causes damage to the kidney itself. And, like they can even have, if they have like a pyelonephritis or something like that, that can also cause like an obstructive picture as well, if it's really that bad, depending on where the infection is, obviously. So it all depends on that. So they can have actually a combination of all of the above.
Okay. And how how does like an obstructive uropathy work? Let's say a patient's got really bad kidney stones. How might that result in acute kidney injury?
So an obstructive uropathy, so it depends on where, well, you can get the obstruction at different levels. So usually, well, a kidney stone doesn't always cause an AKI unless they have like a solitary kidney, or you know, they have a really only one well-functioning kidney. So if they have a stone that's obstructing the urine flow, yeah, that can lead to renal dysfunction with raising creatinine, and because it's obviously
so that's one of our red flags.
Also get can you not also get like a post-obstructive diuresis that can contribute?
Yeah.
So remember, the urologists love talking about that, and it's a very rare complication. So urologists are always, you know, we have to watch out for. And it's very rare. They talk about it all the time, and in our setting, we hardly ever see it. So please don't worry too much about that. You know, you don't really have to monitor for it in the ED. But it is a red flag.
Oh, a red flag. With
so if you've got a patient who's got stones and has got renal dysfunction, that's a red flag. So that's a patient that you most likely would admit. If you had a patient with stones that's got an infection and an obstructive picture, that's even more of a red flag, right? That's like the burning bush telling us there's a big problem here, right? Amy, you were going to ask a question?
No. I just wanted to ask about that post-obstructive diuresis. That was all.
I think it's overstated. Overstated. They always talk about it. It's quite rare. You were going to say something, Andy?
I was just going to say that all the obstructive uropathies I've seen in the ED are actually like more chronic. So they've developed over time. So actually it's not really causing an AKI as per se, like, you know, in this sort of talk that I mention it like that. But it's actually in reality in the ED, you actually, I mean, you've got this patient that has a BPH and they've got postvoidal like residual volume for a long time, which actually causes a CKD as opposed to an AKI. So it's not really an AKI. That I get.
And it's difficult for us sometimes when you're just looking at the patient to decide, is it acute kidney injury? Is there an element of chronicity here? And things like hemoglobin, size of the kidney, all of those things might give a clue, right? But we just have to make sure that we don't forget about it, you know, because we're not very good at monitoring urine really in the ED unless we've got a catheter in. And it's really something to think about. So if you've got a polytrauma patient or a burns patient, somebody that's a sick patient, or even a ruptured ectopic, and you've popped in a catheter and listen, we're waiting for theatre to open up quickly. We just need to, you know, have a look at the urine, empty the volume of urine that's in the bag, because that's how much he or she has peed already, and then try and monitor the urine output that's there. Because it gives us a clue, you know, I mean, that's the easiest for us in our setting in the ED. But depending on the, you know, sometimes we're stuck with these patients, you know, waiting for a transfer to another facility, like a patient in septic shock, or a surgical patient that we're waiting for ambulance or waiting for a receiving, and we kind of don't remember to monitor the urine output, and to even think that this patient is at risk. So I also like that AEIOU thing. It's really cool, because when we have somebody who's got ridiculously looking results, and, you know, we're really worried about acute kidney injury, it's a good way to remember who should get dialysis and who shouldn't. Any questions, any comments, Amy?
I don't really have any questions, but I just want to say it was a really good talk. Thanks, Andy. And I think that it's really important. And I think, like you mentioned in one of your earlier slides, that I think, you know, a lot of the time the knee-jerk reaction in ED is there's an AKI and then just hit them with fluids. But, you know, always think of the bigger picture. So
that's why I like the slide here. That's not everything.
I also get really worried when people are like, just hit them with furosemide. I find it terrifying, right?
Yes, you can try. I don't know if you've ever tried this furosemide stress test, Tammy. I don't know, like, is there a real value for us to use it in the ED, or is this more for the physicians to really I don't know.
I think it's more for us to decide what is the cause of the renal dysfunction. And very often for us, it's perfusion that's the issue.
Yeah,
and if you don't have good perfusion, hitting the kidney now with a large dose of furosemide, when perfusion is the issue, you're actually going to worsen it. And the problem is that everybody's so excited when the patient starts to pee, right? Because that's what furosemide does. It gives you this big volume of urine, but it has the potential to drop the BP because you're losing a large volume. It also has so now if the patient has already got decreased perfusion to the kidney, now we're making the patient even more hypervolemic, even more decreased perfusion to the kidney. So you actually can worsen it. You've got to be very careful with just giving furosemide and just pumping fluids, right? Because also the more you sort of hit the patient with a poor perfusion with furosemide, you're worsening it. It's the same. So much like you can get edema in the tissues and pulmonary edema, you can get a swollen kidney when you give too much fluid. The kidney itself can become edematous, and that also worsens the renal function. So, it's the knee-jerk reaction, especially with surgeons. They love to just hoy extra fluids at the patient, not realizing that actually you're also decreasing the perfusion of the kidney by making the kidney edematous. So it's sort of a tricky thing. I would, and I think for us, a lot of the time, it's actually related to perfusion, but looking at the entire thing, always kind of discuss with someone before doing a knee-jerk, let's give furosemide, because it gives you a false sense of security when you're peeing a large volume, but it's a poor quality indicator. Yes, you're passing volumes of urine, but it's not actually changing the function of the kidney, and it's not changing the prognosis, but it gives you a false sense of security because there's some pee coming out, right? So it's the same with just giving Sodibic to a patient who's in renal failure. It might change how the gas looks, and then you have this false sense of security that the patient is getting better. But all it's doing is changing the numbers. It's not changing how the kidney is functioning, and it's not changing the prognosis of the patient necessarily. Might buy you a little bit of time to get the patient to dialysis or for the vasopressors to work while you're getting the patient to dialysis. But it also gives you a false sense of security.
Yeah, because it says the ICU trial, the BICAR ICU trial says it decreases dialysis, but I mean, if the underlying cause of this renal failure is so severe that the patient is going to end up needing dialysis anyway, inevitably. So giving that bicarb is going to just delay it and delay the inevitable.
And I think that's the problem, is everybody is a bit reassured when the gas starts looking better. Okay, I think we're running out of time. So Andy, that was excellent. Thank you very much. Really
thank you so much.
I'll share it to the academics group.
Well, when we go out, so when you stop it, it's going to export your talk, the video, to like an MP4 format. Save it so that you've got it. Okay,
perfect. I'll do so.
Okay.